We're just in limbo.
I'm gonna call the meeting to order for the would-be held Board of Commissioners. This is an open public meeting. We welcome public input. If you are interested in any comments, if you would raise your hand on your computer and John will pick you up. First item on the agenda is the consent agenda approval of the July 18th board minutes.
Were there any, Marion, did you know the change or did that already get made?
Which one?
To the minutes, do you know that there was a change or did you already call that in?
Already called it.
Oh, right. Motion to approve.
Second,
It's been moved by Kevin. Is there any discussion? Without discussion, all those in favor signify by saying aye.
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 Motion is approved. Points of order, we have two resolutions. Okay. Greg is aware of this, Marion. I don't know if he's discussed this with you or not. We have talked about this in finance committee meeting. The issue is when we meet the finance committee meeting in the third week, we don't have all the information. And it puts a strain and a burden on the CFO to try and get the information together. So the suggestion, and Greg made a suggestion, and it's a very good suggestion, that we move the meetings down to the fourth week of the month. That way, CFO has time to have more complete records for us. And so we prepared a couple resolutions. One is to move it to the fourth Thursday and meet at 11 o'clock, which is what we're currently doing. The other resolution, the alternate resolution, is to meet at 12 o'clock, which is the previous time. So I'm going to put this over for discussion right now and get some opinion as to how everybody feels about changing the meeting time. Greg, do you want to?
I don't have a significant preference. I have found that the 11 o'clock time is a good time. So my preference would probably lean towards 11 o'clock, subject to somebody else's preference being strong.
Fourth week is fine and 11 o'clock is good. Okay.
Anybody else have any input?
That works for me. I'm glad it's the fourth week and not the third week, because I would have had a big problem.
Dr. Brookstool, is that good for you? That you'll be mostly influenced by it after you take over?
I cannot make a decision one or the other. I have to have a schedule in front of me. There's a lot of items in the schedule.
Right.
But I suspect I can easily adjust to that.
Shouldn't be a problem.
So motion to approve the change, transition to a fourth Thursday at 11 o'clock Board of Commissioners meeting.
That is resolution number 471. Is there a second?
I second.
Any further discussion? No further discussion. All those in favor signify by saying aye.
Aye.
Aye. Motion passes. Okay, so we will now take up resolution 472. Public comments. Does anybody want to make any public comments?
None that I see.
Okay. Let's go with medical staff report. Dr. Jimmy.
Good morning.
They're presented today for additional appointments. Jorge Alchamas, MD, Skagit Radiology, who will be working on site as provisional courtesy. Alan Chen, MD, Skagit Radiology on site, provisional active. Deepjot Singh, MD, Woodby Health Hematology Oncology, provisional active. Tyler Willis, nurse practitioner, hospitalist, provisional active. Janice Hessler, PMHNP, telepsych, telemedicine by proxy. Lin Yuan, EO, telestroke, telemedicine by proxy. And Vinod Wada, MD, telestroke, telemedicine by proxy.
Dr. Lemmy, could you just explain what for everybody, what the by proxy means in the last three based on the privileges?
By proxy means that they have primary privileges in another medical facility. And they don't practice here, but we're taking that credentialing at its value because they've done prime source verification at those other facilities.
Okay, thank you.
Is your motion?
Motion to approve the appointments.
I second.
Moved and seconded. Discussion? All those in favor signify by saying aye.
Aye.
Motion passes. Advancements.
Ashley Browning, PAC Walk-in Clinic in Clinton, active. Cindy Coley, MD Primary Care, Cabot, active. Nezra Baruka, MD Telepsych Critical Telemedicine by proxy. Heidi Bradley, PMHMP Telepsych Critical Telemedicine. Marianne Brescia, MD Telepsych Critical Telemedicine by proxy. Tara Kane, PMHP Telepsych Critical Telemedicine by proxy, and Tao Wang, MD, PhD, Sound Physicians Hospitalist, locum, as courtesy.
Motion to approve.
Second,
Further discussion?
can you explain, under the telepsych critical, what's the critical designation?
Critical means that the ER would refer to them emergently. And they would be, they wouldn't be here in the hospital.
For a higher level of patients.
For patients that they're considering having transferred out for psychiatry.
All those in favor of the motion? Signify by saying aye.
Aye.
Aye. Motion passes. Reports.
John Plastino, MD, or emergency physician, active.
Motion to approve.
Second,
Discussion? All those in favor signify by saying aye.
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 Okay, I guess you want to go into your,
We have updated several privilege request forms. First one is the emergency medicine, which, excuse me. With removing the requirement for ATLS, but actually, let me explain this a little bit. Emergency medicine physicians who are board certified by the American Board of Emergency Medicine have all the skills and training required to perform, advanced trauma life support. So it had been determined by their credentialing, by their board, that further training in ATLS and in ACLS is not something that, or ACLS specifically, is not required. And so those who are board certified emergency medicine physicians are not required to maintain that privilege because that's part of their board certification and their ongoing training. Those who are not board certified, for example, sometimes we'll have family physicians or internists who work in the emergency department as emergency physicians. They don't have that training or that ongoing qualification in their board certification, so they would be required to maintain ACLS or ATLS certification. And so we have updated the privilege request form to reflect that.
and that is in play continuously for the non-board certified.
Yes,
So every 2 years they need BLS and every 4 years ATLS to maintain.
Yeah.
Okay,
that's correct.
ACLS.
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 Yeah, ACLS.
ACLS, ATLS. So we present that for your approval.
And I had one more question on the reappointment requirement, and this is on several of them. Documentation of clinical activity within the scope of core privileges requested without significant quality variations identified.
Right.
How is that defined of quality variations?
So our peer review committee
Mhm.
reviews things in two different aspects. One is initial appointment and one is ongoing quality assessment. And so there's a FA and a CA, which is continuous, one is, I don't know what the F stands for.
Ongoing.
Ongoing. So, because we're making a new process involving that and with our, instead of going from JACO to, thank you.
Yes.
The terminology is different.
Okay.
As we go through our privilege request forms and update them, which we try to do every 2 years. We're making those changes in all the new updates. So that they're reflected in there. Some of them have, some of these privilege request forms haven't been updated for a long time.
Okay. All right, thank you.
Thank you.
Motion to approve.
Second,
Further discussion? Hearing none, all those in favor signify by saying aye. Aye. Motion passes. Next one.
The hematology medical oncology form have updated because we have a new hemonc doctor coming on board. And since we'll have one on board all the time, we had him review, just make sure it's all up to date. So this is a normal update with those changes that you discussed. And we also will have a privilege request form for nurse practitioners as well. Looking forward to having nurse practitioner oncology providers in the facility as well. So the first one is the physician privilege request form for hematology, medical oncology, which we present for your approval.
Could you just go back and explain a little bit? So there's two of these privilege requests, they both say hematology.
One's for physicians, MDs or DOs, and the first qualification would be of successful completion of CCGME or AOA approved residency program. And the second one would be for nurse practitioners, which would be very parallel to that, but a training as a nurse practitioner.
So if I look at the headers, it just doesn't jump out that what it applies to. In other words, the hematology medical oncology MSN DMP, and the other one is blank. How would I know?
That is a clerical issue.
Okay,
This is the way the form currently came out on the printout.
right,
Heather and Colleen is still working on to clean up the header.
okay.
So I'm sorry about the way it appears on the form.
No, I would say motion to approve subject to the administrative change so that it's consistent and the
Yeah.
label's correct.
Yeah, they will all look,
Would delay it.
as you see on the emergency medicine form,
Mhm.
they will all look very similar to that. Once the things get cleaned up.
Mhm.
I'll entertain a motion to approve both of these with corrections.
Yeah. Motion to approve item 16.
second,
Any further discussion? Hearing none, all those in favor signify by saying aye.
aye.
Motion passes.
And pediatric newborn. I'm out of order on my computer here. Also, we're updating the credentials for pediatricians, which has also been reviewed by Dr. Gladstone and who is pediatrician required, and basically has that clarification that Marion mentioned, as well as being updated. And I don't know, can't say specifically what other privileges were revised on this,
Mhm.
but pediatricians have reviewed that to make sure it's up to date and that it's cleaned up. But yet, when you look at it, it's not clerically very nice because the lines don't line up. They're
Right.
working on that.
But the reappointment requirements will stay the same on this one?
Yes.
Okay,
Yes.
so these are very
There's no
defined,
significant change of the
Yeah,
pediatricians.
these are
but they've been
very-
reviewed.
these have very defined reappointment requirements, much more
Mhm.
defined, whereas the other ones didn't, so that was part of my question. One's kind of vague. and
Well, there's a
this
lot
one's-
more, there's a lot more different privileges
Mhm.
that may be selected by a provider under the pediatrics for inpatient care than what, like with the HEMOC is a lot more straightforward.
It just talks about risk management and patient satisfaction and
Oh.
stuff on this reappointment,
Okay,
which is kind of universal to all physicians that you sort of want to make sure that they're doing that. Also, on the minimum formal training, it talks about BLS at NRP and PALS, and it doesn't mention anything about that in the reappointment requirement that those are up to, that those are continuously required. Is that, should that be there or not? I'm just asking. Should those
It needs to be,
certifications,
it needs to be, it's a,
because it's in the minimal formal training
Yeah.
at the top, so that's kind of, and it, does that need to be in reappointment that you're maintaining that certification, those certifications?
it is required. Good comment. It is something that needs to be maintained.
So I just don't see where that's accounted for.
Well, the part of this is that these, our providers re-credential every 2 years. And so at the time of re-credentialing, those need to be up to date. And so, like speaking for myself, when I re-credential, my emergency
To be.
requirements still are required, so it would kind of fall into the fact that every 2 years we're re-credentialing anyway. And they have to maintain this during that period of time, so it would fall into that, and I think that's probably why it went through that way.
And they're checked every time before they're approved to go forward.
I just didn't know if that needs to be accounted for on the privilege request form that, I don't know if someone would skip it, is all I'm saying. You know,
Well, they wouldn't be able to skip it because
they have it,
every 2 years,
Mhm.
this form has to be recompleted
Right,
by a provider who's requesting re-privileging.
right,
And so they would have to be current at that point in time. And these qualifications last at least 2 years, so I don't see
so
that
it doesn't need to be.
it
a
wouldn't fall through,
reappointment.
it wouldn't
So-
fall through the cracks, because we would have to have that
Okay,
at the time of reappointment.
but, okay,
This
I
is-
just don't see it on here that you needed it reappointment,
Well,
That's all.
this is also used for reappointment.
okay,
So every 2 years, we do reappointment with the same form.
with the same form
The same
and
form.
under minimal formal training still
Yes.
counts for the reappointment,
Right.
that's not an initial thing, and then this is
And
redone,
this is
okay,
maintained that way.
thank you.
So just one additional point, it's basically a pet peeve that I think is important, and that is. We're obligated to review a lot of documents, many of which we don't know a substantial amount, and certifications are a big deal. It's very difficult to look at a document that's 2 and 3 pages. And hear, well, there's no substantive changes, or there's several changes, and not have a list of the changes. So
Yes.
my request would be that we consider having either a red line copy with it. Or a quick summary, just a bullet things of the paragraph or what's changed, to see if there is anything of substance, because otherwise. We're sitting here, and I've read these all before today, but it took a while, and then I'm reviewing them. It's difficult to really get a sense for what changed, and we don't have the previous document at all. So. That would be helpful.
Great.
Yeah.
We'll make that change.
Motion to approve.
Second,
Okay, further discussion. Hearing none, all those in favor signify by saying aye.
Bye.
Motion passes. Medical staff policy number 17.
Medical staff policy 17, the proctoring policy, which is the new policy regarding proctoring new providers who are coming in and providers who are returning to practice after a hiatus of time they haven't received patients on a regular basis. This has been chopped several times to the credentialing committee and the MEC, and we finally came up with something that the MEC feels is adequate for us. The bottom line is that you did not have a specific method of proctoring people who hadn't been seeing patients for a period of time, or a way to document that. Now, with this policy, there will be a requirement providers who've been out of practice for a period, usually about 2 years. Or who haven't been doing certain procedures for a period of time. To be proctored by a fully credentialed provider. For a period of time, and it depends on what the procedure is, or depends on what type of practice they're in. But be able to document that, and that goes into the records, so we can say, yes, they have had oversight, yes, they are competent in what they're doing, and yes, they're current.
So just a note for anybody that's listening, this, I think, should be considered a monumental improvement. In terms of how someone's credentialed. I can't tell you the number of times that I've heard, so-and-so will be on a proctoring program, that so-and-so will be their proctor. And you just know that it's just a coin toss on how they're proctored, how it's documented, what's required, what's expected, how the person's participating in it, what they should expect from a proctor, et cetera, you know, over a period of time. And so this is really, really good.
And the Department of Health and the DND both are keep an eye on that. So by maintaining those records, we can answer them that yes, all our providers are both current and credentialed, capable.
And these are based on like national standards for the AMA or anything like that. Because a lot of our policies for in quality and documents for nursing and other things have citations of where they got, how they came to these results, so.
I can't tell you off the top of my head where that all came from, because it's been chopped in different areas. We wanted to make this flexible enough for all specialties and all areas in the hospital and clinics. So I can't tell you specifically where they are. We don't have, we might be able to bring that up if we need to, but.
Yeah, it might be good in the future for something like this, if you can cite several things,
Yeah,
that
the
we got some
bibliography.
part of the information from that shows that we're doing it based on national standards or national certification agencies.
I don't know, Shannon might have that already on file.
And we could put that in the policy itself for med
Yeah.
staff policy. We wouldn't put on the bottom of every forms because regulations change or version control, but you could mention it in the med staff policy.
Just so that we know what we're basing it on, not that you all are not super
No, so we may
intelligent,
be able
well
to
experienced.
pull those out and
physicians
add that
inside
onto the
it.
bottom of the
It's
policy.
always
so it's available.
it's always nice to have that kind of backup.
Thanks, man.
And to Marion's point, there are significant numbers of national standards that are available, but quite often we don't avail of ourselves. For example, in bylaws and credentialing, I mean, there's some really outstanding publications that show how credentialing process should work, who should be involved, et cetera, and what the most appropriate or most effective methods by credentialing somebody, and how critical it is. That it's more critical than I think even physicians think at times, because it can be a little, I don't want to say rubber stamp negatively, but it's like, oh yeah, we know this, we know that, you know, so and so. And it doesn't take a whole lot to find out that maybe there's something that we shouldn't overlook.
Well, the experiences that we've had as a medical executive committee in the last 1.5 to 2 years have really made that so that made it aware to us that how important that is. That issues that will come up that have made us really want to make sure we have something written down and we follow this and it's consistent. And so that's what we're coming up with.
2 cents worth of philosophy, you know, if you later on, Shannon's going to give us a very comprehensive report on quality, risk management, you know, outcomes. We're going to get a briefing on the financial summary, et cetera. But all of those are afterthought. They're all the post demonstrations of competencies and plans, et cetera. And so, you know, the whole, it's all we are is a health system filled with providers and support for providers. And so if credentialing is not at the absolute pinnacle of what we focus on, you know, we can expect issues all the way down the line.
Absolutely.
To include billing, to include patient documentation, data follow, you know, and adherence to protocols, et cetera, it's a big deal.
So it's important that when we do our review, that the members of the committee are not hampered in any way from having open discussion and discussing all the things that might could possibly be an issue.
Right.
And clearly working on.
And the last thing I'll say, and again, 2 cents worth of philosophy today, sorry to delay us, but I think it's important. If there's anything that we as a commission are responsible for as a group of 5 in governance, it is the overall quality, the overall governance, the policies, et cetera, you know, and so if we don't start at the top there with, you know, this is really important to pay attention to, you know, we end up having to pick up the pieces at the end, and we have nothing to blame but ourselves, you know, for what happened in between, you know.
Further discussion,
Motion to approve?
Second?
all those in favor signify by saying aye.
Aye.
Motion's approved. You want me, do you have anything else?
I have nothing further right now.
Dr. Brooks, do you have anything you would like to add?
I do not. Well, I will back up one comment. This, partnering policy, a lot of great people out there doing great stuff, but for me showing up here, it just came to the point where I think a lot of good people realize we need to do something. And, I think at the MEC level, and provincial level, this is a good project, so. Yeah, we just realized that this is something to have attention.
Thank you. Dr. let's see, health tech report.
Thank you. Good morning, everybody. I have 2 things for today. The first thing is to let you know that we have our CEOs meeting coming up in October the 15th, which will be in Globe, Arizona, at one of our other hospitals. It's going to be at Cobra Valley Hospital. We decided probably about 1.5 years ago that we wanted to, instead of meeting at a hotel or something along those lines, we've decided to change those meetings to one of our hospitals moving forward. There are a lot of benefits, and we've had one meeting this way. The benefits are really fantastic because all of our CEOs are getting together in one hospital, and there's a lot of cross pollination. There's a lot of idea generation. A lot of learning. And the one thing that we're going to be doing this year, which is different to before, is I've asked the CEOs to come to this meeting with 3 particular things that they have implemented within their hospitals over the last 12 months or 18 months or even 2 years. So, you know, I think that, you know, for Nathan as well as for all our other CEOs, I think it's going to be a great opportunity to take success stories from our other hospitals and for them to be able to take that back into their own environment of their own hospital. So I think that I'm very excited for this next CEO meeting, and you know, if all goes according to the plan that I'm hoping will play out, it will be, you know, really good that, you know, Nathan can share some successes with the other CEOs, but most importantly for Whitby, that Nathan will be able to come back with some ideas that, you know, hopefully will make a difference in different areas of the hospital. The second item today is something that I would like to present to James and to the board, or represent rather, because this was presented at our CEO conference. A number of our different hospitals were given awards for various things, various achievements. And this particular achievement that we presented to Whitby, which I'm representing because I don't know what Nathan did with the last certificate. So this certificate to the board and to James, which I'm going to hand to James, is a certificate of recognition to Whitby Health as a financial turnaround hospital award.
Thank you. I'm honored, but I must say that this did not have too much to do with me. It was all basically teamwork. And fortunately, a very good team was assembled, and it worked very well together and advanced. And that's the reason we were able to come where we are, is because everybody working together. So it's not just one individual. So it's a lot of people.
Absolutely.
That put together, but thank you.
Couldn't agree more.
Just a quick question. You said it was a turnaround award. Did he bring us a 360? Is that where we are?
I should have stipulated that.
Yeah. Or I was hoping for a 180. Or at 180, yeah, just gonna stay there.
Running a hospital's like turning an aircraft carrier.
Yeah.
So, you know, we're in the phase there.
And just one thing, the conference he mentions in November, not October.
Sorry,
You said October, it's actually November.
it's November, sorry, excuse me. I
When is it in November?
think it's the 15th,
15th,
yeah,
14th, 15th, 16th.
14th, 15th, yeah.
And the only, just information, it looks like the only day that almost for sure we'll have to change the board meeting would be one on Thanksgiving. Where we bump it up, the week prior or maybe Tuesday.
For November and December in the resolution. So those months will actually be the third Thursday, so they don't fall on Thanksgiving or Christmas.
That's great. Then we don't have to scramble. We know in advance.
Great.
Anything else, Tom?
No, thank you.
Thank you. Okay, Shauna, you are up.
Welcome, everyone. So for quality, August report for the board is as follows. So quick highlights, continued engagement with Meditech Expanse, parallel testing, as we're working to ensure that data is flowing for analysis. Celebration and events for Whitby Health executives and staff representation at Dr. Sanders. Retirement celebration, approximately 40 years with Whitby Health. And then also the Island County Fair and the upcoming tour, it would be this Saturday. So, looking forward to all of them. All right, current accreditation and licensure or notes of importance. We had a successful lab CAP survey in July. No concerns noted. And then Meditech Expanse continuing that parallel testing for those October go live dates. Workplace violence events, we had 8 for July, 5 were verbal, 1 physical, and 2 were actually verbal physical. So we're continuing to partner with workplace de-escalation classes through Washington State Hospital Association, and 1 is in the fall of this year. We've done that already. Data analytics,
Shannon?
yes.
Would you be able to change that in the future to indicate whether or not the event was a patient-oriented event versus a staff event? In other words, is it a staff member that's doing something, or is it a patient and to a staff member?
Yeah, these are patients, so yeah, we won't separate those going forward. These are patient events, and then we track if there's injuries, of course.
Okay.
From there. Data analytics, we're focusing on the metrics for ACO, Accountable Care Organization, our quality performance improvement and regulatory with Meditech Expanse, making sure we can capture that data going forward in October. So quality data updates, employee health, we're establishing a new employee health software system to assist in tracking the health information for our employees, so they will have real-time access to their own immunizations, their employee health records through this platform. We're working through that process right now. It is not live across the organization yet. The eye to the future is really those initial discussions surrounding flu vaccines for upcoming services here for our healthcare workers. Education department continuing with Meditech Expanse and training for go live after. So what does the training look like for if you have Expanse, you're a new employee, what does that look like and what kind of training will that entail? Clinical Skills Day will be held this month for the clinics and also 1 in November for the hospital. And that's 3 days. Our CNA program is still on the docket to go live in January 2025. So more to come and more discussions to be heard at the board meeting. Medical staff credentials and MEC appointments awaiting board approval, 7 initial and 8 reappointments. And the credentialing applications that are in queue are mentioned for there and all of those locations. Our patient experience trends for HCAHPS are inpatient surveys, very high numbers and above national average. You can see the national average is below 91% for hospital cleanliness. It's quite significant. Patient experience trends for our outpatient scores. Year to date, my provider spent adequate time with me is 4.65, and the appointment process was easy. And at the last meeting, we had asked how many surveys was that information for, and that's 1,000 surveys attributed to these numbers here. And our patient experience trends for outpatient, 90 days, would you return for services? And it score with how many services were returned for each category and the location. And again, very high scores on a 5-point scale. Any questions?
Do we know when the marketing will start for the CNA program?
What,
But for the CNA program, like
probably November.
November, and then how long is that course?
6 to 8 weeks.
6 to 8 weeks, that's kind of what I thought.
We're still in planning stages.
Great, thanks.
Now, we anticipate a very exciting report from our CFO. Paul?
No pressure.
Okay, so here we are, July 31, presenting surplus of almost $24,000. Which compares unfavorably to a budget of $311,000. Meditech expense was budgeted to the costs associated with Meditech expense were budgeted to go away July 1. And that migration has continued. So we are still incurring costs relative to that migration. But nonetheless, we're sitting here with a surplus of $24,000. Outstanding revenue for the month, $12,387,000. Operating expenses, $12,700,000. And both of those numbers exceeded budget by 5.2% and 8.7%. Non-operating revenue, which includes grants and things of that nature, exceeded budget by $113,000. So, high patient volumes are paramount to net surplus, and we saw that in the month of July. Discharges inpatient exceeded budget by 27%. Emergency room visits exceeded budget by 16.4%. Outpatient visits, 11%. And surgeries exceeded budget by a very small amount. On the clinics side, primary care and walk-in clinic visits measured almost 6,000. It exceeded budget by 1,364, and that's a 30.5% increase over budget. Wow. Specialty care visits exceeded budget by 12%. So in every facet of our service platform, we exceeded budget. Days cash in 24.2, and that's a 3.5 decrease. And that stems from a reduction, of a reduction in accrued expenses of about $1.2 million. So reduced our liabilities. Consistent with that reduction in liabilities, we see a reduction in cash. Net days in AR, a 2-day decrease from the prior month. So we're sitting a little above 60 days. February, we can consistently drop month over month to the level we're at now, which is 6 days.
Paul, do you think it's realistic that we can get between 45 and 50, or do you think we'll stay above 50?
In my 2-year tenure here, we've been as low as 49 days, and so certainly that's achievable. And we've come a long way in 2 years. So I think 45 is not out of the question. moving right along, here's some statistics, patient volume statistics, current month over here. Year-to-date numbers here, and John makes me make those numbers a little bit bigger. That's good. Positive variances here. 24 acute discharges, higher than budgeted number of 88. We're sitting with an average length of stay for the year, 3.7. And emergency room ER visits measured 1876 here on a budget of 1611. So we are very busy. Revenue wise, our July numbers were the highest they've been all year. And we'll see that on a graph in just a few minutes. FTEs were higher than budget. We've got a variance of about 10 paid FTEs for the month. But that's not to be unexpected, given the increase in patient volumes that we're seeing relative to budget. Move along, John, to the next.
One thing to point out, with our recruiting efforts, we've seen 7,000 more patients in our clinics than the last. So that's a huge dynamic.
That's
It's a huge number.
Here's a comparison of assets and liabilities, current year versus 31. Increase in assets, smaller increase in liabilities. And John, if you drop down to the statement of revenues and expenses, here's the $23,925 surplus for the month, and on a year-to-date basis, we're sitting with a surplus of almost $1 million on a budgeted loss of $534,000. John, if you'll move along to the next page. We've got a trend of some statistics here, and make that just a little bit smaller. Thank you. Here's that reduction in net AR days from a high of 61 in February to 53.6 here in July. Days cash on hand, we've seen a nice improvement since the low in February of 5 days. Sitting presently at 24 days cash on hand. And here's a graph of total operating expenses, which consistent with the net revenues that were the highest for the year. Our expenses were higher than any other month. On the next page, we're going to see a cash forecast. I'll drop down just a little bit. Come to the days cash on hand right here. So we started the week at 20 days cash on hand. This is a picture of select weeks throughout the next 26 weeks. And you just get a sense for where our cash position is now, where it's going to, and where we expect to be 26 weeks from now. And this 18 days cash on hand is post levy payment, bond payment, principals and interest, and all that. On the next page, showing, this is something we've not seen before, it came to my attention during the month. This is going to demonstrate the difference that one person can make. What we have in this column here is These are the number of patients that presented in each of the 7 months of this year without insurance.
Well, can you just, for everybody, talk about the column header? What does that mean? You just say IPA accounts, and what's underneath it?
These are patients that presented without insurance and who we have a staff member who held their hand and walked them through the process of getting on the Medicaid rolls. If you go down to the total column, or the total row down here, you're gonna see that's 137 registrations, generating almost $1 million in charges. That without that handholding and walking those folks through the getting on the Medicaid roll, that would have been bad debt. Instead, it turned into $2,000 cash to us that we would not have had that handholding not occurred. My thanks go out to the person who does this work and serves the community in that fashion.
Great job.
Any questions? August is a 3 payroll month. So we should expect to see some deterioration of our days cash on hand. However, we are seeing a nice increase in our cash collections. So hopefully we'll get an offset. That's the plan.
Thank you, Paul.
My pleasure.
And Nathan, you got the phone. I'm gonna turn the first year over to Tim. Since he's here today. And there's so much going on in IT, that I'm really gonna go.
Well, good afternoon. Been a while since I've given a report here, so I'm gonna go over a number of things, especially facilities. IT, we continue to rotate through 12 current projects along with Medtech Expanse. The steering committee prioritizes projects for IT and the organization, and we're trying to maintain 12 on the docket. That's what we can maintain with the resources we have. We're adjacent to doing the Medtech Expanse. So right now, Medtech Expanse is the main driver for IT. As far as facilities, there's been a lot going on. There's been a lot of improvements going on. We've almost completed all the flooring improvements. We're working on the lobby will be very shortly. We have all the flooring picked. It's going to be porcelain tile for the majority of the lobby with new carpet tile in the living areas. So the carpet tile, so it does get sanded, it can be easily replaced. There are a number of the buildings painted. Goldie's been painted. The Women's Care building, we're kind of working through and having a uniform color scheme on our buildings. So the next building that's going to be treated, not painted, but is EMS baby. Since I've walked in the door, that's been a high priority. It's got the wood siding, so we're going to be getting that done very shortly to spruce that up. You know, with it being right on the highway, it's important, you know, visual. Freeland will probably follow that next. It's also a wood building, so it won't be painted like the Women's building was, but you know, things that are being visually improved on. We continue to work on signage. It's always a work in progress throughout, you know, slowly updating different areas of the you know, organization. You know, the signage better, more uniform. ER has some new signs coming in. We've done a lot of different, so signage continues to be worked on. We updated, in case you haven't noticed, the irrigation outside. A lot of those little pipes that were sticking up and always broke because of the erosion on them, people were driving on them. Those have been removed and we put in a drip system. And so some improvements there on the outside, along with some striping and we fixed a number of parking lot areas of the EMS and Oak Harbor. We have tree roots here on the front of asphalt up there that's been fixed and restriped. building we just purchased for hospice. That's what part of that parking lot was repaired. The building was, the parking lot was restriped. So a lot of things being done in the exterior of the building, just a lot of cleanup, power washing, get rid of, algae growing and moss and everything. So a lot of work being done.
People are a little upset that they can't swim in the lake anymore in the parking lot. So that was good that you got that hole fixed.
I had a bird that whispered in my ear quite often. That hole out there, so we-
It was a pet
peeve. And then, of course, the imaging project is now complete, so we have Floral, we've seen our first patients in Floral, so after not having fluoroscopy for 3+ years, all the rooms that we see, the new X-ray and Floral, so that's going very well. We're looking at bringing PET scanning in, we should have that in by the end of the year. We have to add an outlet outside, only back where the PET scanning will back into and plug in. That outlet is about 6 to 8 weeks out, so that's kind of. We should have everything in place by the end of the year, before the end of November, December, so.
Is that the contract PET scan unit?
Yes, yeah. Trying to think. The EMS levy has passed, so that's a huge lift for the organization, that's gonna see an increase of $2 to $3 million coming into the hospital. Yes.
Can we, would it be possible to know kind of what that's gonna be spent on and the timeline? Because when I go out and do speaking to the public and stuff, it would be nice to thank them for that and say our vision for that money is and in the next 2 to 3 years, you should see these kinds of improvements. That would be really helpful.
Probably talking about DOH.
Yeah, I think the biggest thing is DOH, so we have been subcontracting out to EMS Fire on the north end. And we can no longer do that, so we're gonna have to increase our staffing. We have to continually replace our ambulances, we have an order for 2 new ones coming in after having 2. We also, Chris is gonna be putting in another order for 2 more. We are down rigs, we're spending more on repairs than actually the cost of a new one on an annual basis, so. It's gonna be equipment upgrades, it's gonna be new extra staffing to better support the island. We've had staffing shortages where we've had to stop, pull back rigs because we didn't have the staffing to do it, and we're doing a lot of coverage. So a lot of different things like that is what that money's gonna be helping to support. So.
Thank you.
Are those ambulances, are those diesel powered?
Yes. And they take about a year. Once you order them to actually get built and put together, so even though we place an order today, it's gonna be, a year out plus before we see them.
And do we have enough infrastructure for more staff and the ambulances up and down the island, since we won't be able to use would be fire resources?
We do, yeah, I think we've been working on the plan of how that's gonna work, but we do, yes. Any other questions? Just trying to think of everything, there's been so much going on, we had a great D&B life safety survey, very minimal findings, just quick fixes. We had, as Shannon mentioned, we had a great lab survey for CAP. Those findings that we've ever had here, so it's going very well with lab.
What's go back just a minute, DNV, did you say life saving?
Life safety.
Life saving.
So they look at all the life safety, how the, basically fire sprinkler, backflows, all the things that we're doing to make sure the building is safe, fire alarm system. A lot of testing that we have to do on an annual basis, just making sure we have all the right documentation, the building's being well maintained. We're doing fire drills, property drills and ORs, just a lot of things. 80% of findings are usually around life safety in organizations, whether it's DNV, JACO, whatever it is. Because there's a lot that engineering has to maintain on a regular basis, that they expect us to meet. They look at emergency preparedness, are we doing the proper number of drills, are we involved in outside agencies? So there's a lot of that goes into that. So to have very, minimal findings is very good. When I came here 5 years ago, we had a stack like this, and now we just get minimal findings. So it's just
great.
A lot of hard work, and the engineering team does a great job. Sure we keep everybody safe. So, I guess the next thing I want to talk about, if I may, is, as I mentioned, I think last time was a board meeting, and I'm sure, you know, I've talked to Marion and Mr. Golder and Greg Richardson. We put a lot of attention into the organization. One area that has been neglected is emergency room. So we looked at, you know, my team, it's hard to get into the emergency room that's 24/7 and just fix it, right? So we made the decision that we needed to do a finish upgrade in the emergency room. So that went out to bid, about a month ago. On a public bid, we got 2 contractors that did submit bids. Basically what it is we're gonna be putting in new flooring, all new doors, new paint, new ceiling tiles, the lighting that has not been updated is gonna get updated. We're gonna put wall protection everywhere, new cabinetry, new nurses station. And just a complete uplift, which is gonna be a huge impact on morale. It's gonna be a huge impact on patient satisfaction and their perception of care, right? When I've been AOC, I've had to come in on a Saturday and help calm people down that were very upset because they felt like they were getting poor care. They felt like the facility was filthy. And it wasn't, it was just old. It's abused and it has not been addressed in a very long time. So we made the decision that we go out to bid on this. We got our prices, two contractors bid, a high bid and a low bid. The low bid is from a company that has done a lot of work for us. They actually are the company that just did the imaging project. They did the group room down at Freeland for behavioral health. They also did our seclusion room in the emergency department. You know, Paul and Nathan have agreed that we have the ability to move forward with this. But just so the board is aware, and I would ask for your approval also because of the cost.
Was there any money in the budget or is this completely new requirement?
New requirement. We had reached out to the foundation to help support this. That was undoable at this time, but we had a high bid from Aldridge. The base bid was $991,528. We had an alternate. The alternate is the front reception counter. When you walk in that little round, that area, redoing that space right there. Their alternate was an additional $56,978. Trico, their base bid, this is the low bid, was $779,632 for the base. And then the alternate to do the reception area was $58,977. So the biggest difference between the, you know, I think they're pretty well close as far as the bid goes. I think Aldridge mainly hired because their electricians did not actually come and do the walkthrough. I've walked both contractors through with some of the subs. I think the biggest difference is they went off some of the drawings that were submitted. And because they didn't come to a walkthrough, they didn't get a full understanding of the scope. So I think they were about $150,000 off on the electrical. So that's probably the biggest difference.
Are those fixed price bids?
Subject to, I mean, I don't foresee, I mean, they've done, we're not doing any construction. It's just a finish. And it's why so expensive, you know, because cabinetry is probably the most expensive part of the project. Doors and flooring, pretty minor. We're putting wall protection everywhere so that we don't have the continued problems of holes in the wall, scraped up door frames. But it's gonna be phased, so, because we can only do so many rooms at a time. We're gonna start like with the fast track area. Once that's all done, then we'll do 2 rooms at a time. So they'll come in and they'll strip down a room, redo it, reopen them back up, and it's gonna be about a 3 to 4 month project to get it complete. So that's the phasing of it. You know, where you just can't come in and just do it all at once. This is what I really asked to the cost of the project lately.
So it's about a $200,000 per month add.
And I've given Paul an update on as far as cash flow expenditures look like. We would not start the project until at the earliest after October 15th, after that's like standstill live.
What do you think the impact on patient care will be?
Minimal. I've walked it, Debbie and Kate, the managers, supervisor and emergency department walked through the contractors with me. So they were part of the plan and the process. And there's gonna be an impact no matter what, but it's gonna be, we're gonna do it as minimal as possible.
It's just where the trauma rooms tied up. It's kind of.
And most people are
Alternative
very.
area for that.
Yeah, they'll use the fast track or they'll use some of the other examiners. They have plans to what. We've done this in the past to some extent when we've had to, re-wax floors or shut down the room. So. But they're excited. It's excited to see this happen.
Most people are very comfortable when they see something being improved. And it's sort of. So that probably, matter of fact, you could do that, just keep all the sheets up and stuff for quite some time, and people will think you're improving it. Still improving. Yeah, still improving it. What do you need from us?
Due to the cost, just the approval, just to project, Rex approval to move forward with this.
Is that? Some kind of a motion?
Okay. This is the first time I've heard of this. And this is something that should have gone through the finance committee. So for sure. I don't know how the rest of you feel about it.
Yeah, that was gonna be my next point, but yeah.
You have an opinion on that?
Like going through the finance committee?
Yeah, and this is like, have you heard about this before? No, I think we need a little bit more advance notice on this.
Bring it up the next one.
Yeah, we need to take a look at it.
What's your commitment date? What have they given you in order to?
We don't have a date.
Okay. All right, so it's not an emergency, so to speak, for the emergency.
So we'll put this on hold until we've had a chance, as an entire board, the other two members included, to review this. Do you have anything else too?
No, that's all.
You have a couple of guys that I've seen periodically in the halls, and the engineers, with carts, etc. I don't know what you do, but they're just so happy. I mean, it's absolutely contagious. You just, happy Wednesday, So, I'm not gonna say they're tough on something, but they're very happy people.
We hire for fit and we want a positive culture.
Yeah, well, you got it. They're great.
Okay, Nate, you next.
As far as operations, we have 3. One has already started, 2 more at Freeland. We've talked about those in the past that we all replaced by the end of September. Our new general surgeon will be here in 2 weeks on the 25th. One of our orthopedic surgeons will be here Monday. And our second orthopedic surgeon will be here in September, end of September, I think the 23rd. I have another full-time wound care specialist joining us at the end of October. Our oncology.
Can I ask you a question about that?
Yep.
Where would a wound care specialist work?
Here in the hospital through the MAC. It's mostly done through the MAC, and then we have an area in the back hallway by surgery where they are treated.
I see.
Oncologist will be here August 31st. This behavioral health still growing, still doing very well. Got a new remote telehealth specialist that's going to be starting. And then we just hired a new department manager for that department. She'll be starting, I believe, in 2 weeks. Around the end of the month. Pharmacy update. We're getting really close to expanding our hours to include Saturdays. It's already the basis on staffing right now. I think they filled the last 2 positions. I'm not sure. Rehab, we opened our rehab place back up over in Oak Harbor, and we've got our pool up and running again. So that's all good things.
That's a big deal.
And then we do have, we have reached agreements with our midwives, 2 midwives to join our women's health services. So that'll be starting next month. One of them will be, the other one will be as soon as she finishes her training. I don't have anything for nursing today. I think it's going good. A lot of pressure on everybody right now from the Meditech Expanse project. Getting close to our deadline, so emotions are coming out a little bit. The stress levels are up. Seeing some pushback in some areas, but I think that'll be okay, be easy to overcome. Human resources reports, John, we looked at the report that Lahala sent. So Greg had asked back a couple of meetings ago, I think about how we're looking at and comparing our pay rates for everybody. So Mahala put this together. So basically our approach starts with the local area market. She looks at the other providers in our area, try and make sure that we stay in line and stay competitive with that, and also stay within our budget. On the next slide. Then she expands a little bit, goes out to more, a little bit more regional, a little bit bigger facilities, looking at what's competitive. So looking at other similar jobs in healthcare, maybe not hospitals, looking at the availability and then cost of living, things like that. And then she gets at least an annual, sometimes a biannual report on market data from pretty much the state level. So a good example, the most recent one, we used our survey, compensation survey we got from the Northwest Healthcare. Takes in all of the Puget Sound area and some others. This was part of the WSNA wage reopener. Took place early this year. So go ahead, John. So here's some numbers. So all participants, as far as acute care, all participants for RNs from the clinic. Our more localized regions, so you can see the rates there from minimum up to maximum and over to the right is where our ranges currently are. And I think I mentioned before, one of the things that we're challenged with is our maximum range is pretty much way out of market. And so we've increased the other two, but we have not increased our max. So we're working to try to get everything back in line with those as we go through the contract negotiations. Go to the next one, John. So who do we compare to? We compared ourselves mostly to those three: Skagit Regional, Allen, and Jefferson. Same areas, similar positions, similar size hospitals. And here's a comparison of where we are compared to where they are. You'll see we're actually above. The mid-range is pretty close to everybody, but we're actually above in the other areas. So we are remaining competitive and trying to recruit, retain everybody.
And that's just across the board when you have those three numbers when it says
Yes.
max. That's
So like an RN, so this is specific to RN, so a minimum would be like someone who's fresh out of school. Mid-range, this is all based on years of experience. So then the mid-range would be, I think ours is probably around 10 years of experience. The max would be when you get past, I think it's 25, 10, 25 years of experience, and that's kind of where they max out.
So they don't base any on education.
They would.
There's no factor for education.
There is, that's an add-on to this rate.
Okay.
Yeah. So this is just the base rate. So, certain skill sets add on, and house supervisor, masters, whatever will add on to this rate.
And would those be full? I mean, that's a 40-hour week.
So that's their hourly rate.
Right.
Yeah.
But I mean, is it assuming a 40-hour week?
Yeah.
Well, I'm not great at math, but 70 times 20 is $140,000 a year.
Yeah.
For a nurse, that's not bad. My wife was a nurse, she would have killed for $60,000 a year.
So that's where our, like I said, that's at our
That's pretty decent money.
25 plus.
Yeah. Yeah.
Okay, John, go ahead. So just to kind of clarify, she looked at, might be exclude the bigger facilities, and it's obviously just they're operating margins and expenses and everything. It just puts it in a little bit different category than we are. So we really aren't trying to compete with them necessarily. We have some benefits that they offer that we just so. Sure. And go to the next one. Local area market wise is important, just making sure that we don't pay, if we pay too little, we're not going to attract people. We pay too much, it's going to hurt our budget. So we really just try to stay as close to home as we can. Excellent, please. I think that's it. Yeah. Okay. So that just kind of a quick explanation of how we're looking at our market rates and how to stay competitive.
Tell the hall, thank you.
Other than that, not a lot from my side. The Expanse project is our biggest struggle right now. Don't see any big issues in the way. I can say that over the last, 6 months or so, we have been or maybe I should say, I have been pushing everybody at the management, the middle management level to really review their departments and get a good feel for their expenses, but mostly for their chargeable items. This is part of our charge reconciliation and capture in the strategic plan. And so they've been doing a really good job of that. There's still some work to be done, but I can give you one real quick example of what came up to us last couple of weeks. We had one department. First of all, all of their chargeable items were showing up in the system under a different department. So that was problem number one. So when they dug into it and started looking at numbers, there's one item that we were charging $700 for, $700. Our cost is a little over 10,000. We should be charging in the neighborhood of 20,000, 21,000. And we used 42 or 43 of those this year. So opportunity, yeah. So that's the kind of things that we're, I will say, hoping to find so we can correct, right? But that's just an example of the things that we're really trying to get focused on and helping our charging. So I think just in those 10 items, they were all from the same department. 1.5 million is what I should have charged, and we charged about 500,000.
Yeah, but if you take the example that Paul brought up from Laura, and that, you've got a great example of what it takes in addition to try to increase income, patient flow, and just reduce expenses, but to try and find where you're not capturing it, you know,
It's huge.
it's huge, it's gigantic, it's huge, and it's free. And it's free. Nobody got a penny extra in their annual salary.
It's outside of volume increases, it's outside of increased expenses, it's just what we're not doing as well as we could.
Yeah, no, that's a attaboy, attagirl.
That one instance is 42 at 22K, that's $925,000.
Right.
So,
Yeah, just free money.
yeah,
I mean, money that's sitting there.
well, money that we're owed that we're not collecting.
Right.
That would pay for the ER renovation.
Right.
Exactly.
And that is a high dollar item, right?
Yeah.
That is one example. We found a couple more in the surgical area that are similar. So they're doing what they need to be doing, and it's gonna pay off. I think that's it for me.
So a couple things, obviously, from our standpoint, strategically, it's all about driving business, relationships, community awareness, et cetera. We obviously have a growing marketing department, new marketing chair, et cetera. I'll give you an example and something that I would like us to just really work on, not that we're not, and that is primary care. In other words, we've got a significant increase in primary care providers and capabilities with all the ancillary staff and the locations that I would want to know, and I'm not asking for today, but I would want to know, are we out of balance between the marketing and the conveyance of the opportunity out there and the provisions that we can provide? I've had no less than 3 neighbors in just the last week saying, you know, oh, you're a commissioner, you know, well, you know, I need a doc. And I said, well, you may need a doc, you need a provider, okay? Here's what you do, you know, so, and then I went on the website and I didn't really see that it just jumped out, you know, need a primary care provider, click here. You know, something that drove somebody to how they get a primary care, which we've got, you know, a tremendous amount. So that would be number one, just what can we do to get the word out as simple as possible so that people know what the process, who they call, you know, as opposed to start searching for clinics, you know, and have a driving force. Second thing, aquatherapy. One of the only ones to have aquatherapy. I would love to see that we are putting the word out, not only advertising, so to speak, community-wise, but Island County, the Navy, all of the local PTs, they need to know that we have aquatherapy for referral. And right now they don't, you know, and it's a tremendous facility. So that would be 2 things. Once again, word out.
So we have a big push coming, probably gonna start in November, once expanse is done. I have not done much marketing. I want to get this project up and going. I will also say that our new providers fill up very quickly. And so I don't want, you know, we have to balance the fact that I start advertising hey, this is how you get a primary care provider, and then they still can't get in. It's a great problem. So we'll have a big push in November. With some marketing stuff, and we'll add to that and expand that even more starting next year.
Right. Well, and one, just an I thought, and Dr. Lemmy and Wickstrom could easily jump in with more authority than I have, but one of the options that we have is to set an expectation, that, in other words, a schedule to meet or have, you know, who your primary care, where would you go, you know, who would it be, get there, you know, maybe start to fill out some information, but not necessarily have a near-term appointment. You know, it would be down the way. I don't know if that makes sense, but just so that we latch on to them.
Yeah.
You know, and say, this is, you know, you, given your location, you'll probably be here. These are the providers. We're gonna send you some information, complete this if you would, and we'll start the process of getting you into our system. Does that make sense at all?
I'll comment on that. So our walk-in clinics, we actually promote the primary care clinics quite a bit and steer people in that direction, and we get them started in the process. They generally go on a wait list because first visits are generally somewhat delayed. And occasionally we try to make a couple phone calls and upgrade that. And that the process actually starts in the entities we have in place already. Then we have ratios. We particularly down in the south end, we are looking for primary care providers right down there. A typical wait for primary care appointment is probably depending on the provider around 3 months. Which compared to the other clinic, it's not that bad. And that's one of our regional competitors.
Right.
So it actually works between those two entities quite well, but in the end, you brought up a good point to the balance. We actually need more everybody, primary care. If primary care was full, my clinics probably would not exist, for example. So, but right now, recruiting, we're in a very we're in a very positive spin with our recruiting and walking clinic and primary care both. So with Dr. Miller and what he's done at his level and such, and our recruiting to the clinics, everything's getting better and better with time.
Yeah.
And hopefully your neighbor will eventually have quick access to primary care with us in on the help need be. And this will come to a better spot for everyone to be.
Right. Well, it's just, you know, again, from a strategic governance standpoint, it's so crucial, and I'm just saying it out loud. Certainly Nathan and his group knows this, but you know, the more we drive that, the more we drive everything. And that was what was missing for years and years and years. We didn't have the capability, and so, you know, there wasn't this rapport, and this wasn't this constant interface between the entire health system through primary care, emergency care, of course. You know, and next thing we know, we've got diagnostics involved, and then we've got treatments, and we've got other specializations, etc. But it's got to start at some version of either a walk-in or a primary care.
I think Nathan's got a good timeline on it, and a good glide slope, but if we start advertising, yes, you see here. And it takes 3 months or so to get an appointment. You may be developing a negative opinion of what we're doing, say, oh, we're gonna do this, and we can't get them in. In general population is not gonna be satisfied with waiting 3 months when this is a new appointment. I need to be seen now.
Well, that's why my point, excuse me, just 1 second, my point started actually with a question. Do you think we're in balance between the capabilities and provisions we have versus the marketing? And so, and I accept that answer readily. Yeah, it makes a lot of sense.
There's still a lot of internal things with our clinics that we gotta get in place and just leave it there. And that's gonna take a little time. And now we're honestly out of space. So that's another issue, but we're also gonna have a new and completely different patient portal and self-scheduling as a part of Expanse. And so our current one gets a lot of complaints, our call center is getting a lot of complaints, so not going to push until those things are. Yeah. One last thing, employee picnic is next Thursday. If you guys want to stop by and be serving from 11 to 2.
Where is the picnic?
Will be outside.
Perfect. Okay.
So can we come and serve?
I'm sorry,
Can we come and serve?
absolutely.
Okay.
Absolutely.
Do we have to schedule something?
we can schedule, we can send it to you.
Okay, great, thanks.
Okay, I think that's it.
Anything else? General board items, anything? Okay, we're gonna go into executive section. I need to know approximately how much time you're gonna need.
Which time?
I need 15 minutes.
Probably need 10.
Maybe 5 or 10, so. 25 minutes.
Let's go half an hour.
35.
35
After
minutes.
last time, let's go 30 at least.
So let's do 30, I think.
Let's do 35.
35, okay.
So we'll be back here at,
12:55.
12:55. Okay. Okay, we have just finished our executive session. We have made no decisions, we have taken no votes. So we are going back into a regular session. We'll do commissioner comments. Greg, you can start.
Boy, a lot today. I thought it was a really good discussion on a lot of different topics. Obviously, from a logistics standpoint, that was great. Hearing from Tim, because so many times you just don't know what's going on as far as the other, obviously, we don't micromanage the day-to-day facilities, et cetera, but it's really impressive. The increase in the patient flow and the services, commensurate with revenue is important, and I couldn't be more impressed with the idea of identifying areas where we can capitalize on billing based on items that were missed, and also capturing claims for insurance that would be missed, that sort of thing. Those are I just consider them significantly important from the standpoint of managing an organization well, and looking for that. So pass on those kudos and to you as well.
Whatever he just said. And I'm
Scratch.
Yeah, things are moving in a positive direction, and a big reflection of that is that people in the community are getting more care and getting care on the south end as well as the north end, and that's really important. And the rehabilitation services expanding on the north end with the aquatherapy and things is a big benefit to the community. And I'd be remiss if I didn't mention the Tour de Whidbey is this weekend, and be careful on the roads out there. There'll be over 500 bicyclists on the road. And so we appreciate the community's patience with that, but please be safe.
Anything else? Okay, our next meeting is going to be. You have an add-on?
The board approved moving the board meeting from the 3rd week to the 4th week of the month. Because credentials are presented for approval at the board meeting. Moving the board meeting to the day prior to the MEC may delay providers from getting credentialed for a full month.
Can you move that date?
We discussed this earlier, with regard to changing.
So if we do that, and we want to avoid providers possibly getting delayed for a full month getting credentialed, that would also involve moving the medical staff meeting and moving the MEC and moving the credentials committee, which precedes, they're all in alignment.
Okay, so how is it, I'm just asking, because how is it gonna delay it if we push it back and not up? Right, because your meetings.
So the MEC, if we move this to the last Thursday of the month, MEC often
Just the last
will be
Friday.
the next day.
Yeah.
And so the MEC approves the credentials. And then the following board meeting is when they're presented for approval here. Which means that would be,
It'd be one extra week, not a month. It'd only be one extra week.
if we meet beforehand. On some of the months, we were looking at the calendar of this, there's several months of the year that it would actually delay them for 4 weeks. On the months that have 4 weeks.
Because your MEC meeting is the first Friday, right? Or the
No,
last Friday.
no, our MEC meeting is the Friday preceding the medical staff meeting, which is the first Tuesday.
But it's I don't see how it's gonna delay it more than a week. But we can look at that because your MEC preceding the board meeting doesn't change.
No, the proceeding.
So you present them, so now you're presenting them on that Friday. And the board will be here, but the board's here. It doesn't delay it other than a week. Because we're not waiting, they're already been approved by MEC. Right?
Right.
So this is the last step, so I don't see how it would delay it by more than a week. But we can talk about it offline to make
Look at
sure.
it more, but I just want to make sure before you close today, that you understand that could be a complication. It would delay it
A week
or
is the
more.
way I'm looking at it.
Well, if right now we're in MEC approves them on, for example, first, if it happens to be the first Friday.
Yeah.
And it's a 10-day window roughly.
So it'd be an extra week. Because since this is the last step, it wouldn't be another month, because we don't have to go back to MEC for it.
That's
Right.
true.
It would just be an extra week.
And we're trying to chop that, and then that brought up, and I just want to make sure we thought about that
Yeah.
before.
Yeah,
we
that's,
finalize
that's
everything.
just, that's just.
Okay.
Let's make sure.
We'll go with that. We'll keep looking at it though.
Yeah, we can discuss further. I'll get with Shannon and Heather and make sure, but I don't see how it'll really affect it other than maybe a week.
Okay.
So, and if we do see it's a problem, we can always reach out to you and do something about it.
I just want to make sure we.
Yeah.
Good
thought, yeah, good thought.
I don't think we even, yesterday, I don't think we even thought about that
Yeah.
being a complication when we were in the finance.
Yeah.
Yeah.
The resolution's been passed, so we would need to
Yeah. We had.
do a resolution for potentially for next board meeting too.
Yes.
So while we're all still here, I want to make sure.
Yeah. We'll look at it and we'll let you know if there's a problem
Thanks.
before that, yeah.
Great.
Any other business?
Our next one will be on the 28th, right?
Yeah.
26, right?
Or the 26th, I guess,
26th.
26th.
Okay, next board meeting is Thursday, September 26th, at 11 o'clock. No further business, we'll stand adjourned.